So it's now been about 8 years since we had the first results reported from studies looking at aromatase inhibitors in the adjuvant setting. And there have been multiple studies. These have included studies that have compared tamoxifen versus an aromatase inhibitor as the initial therapy, studies that have looked at a crossover approach where 5 years of tamoxifen is compared to 2 to 3 years of tamoxifen followed by an AI. And then, of course, there's the MA17 approach where after 5 years of tamoxifen, women were randomized to an aromatase inhibitor versus a placebo. And looking at all of those studies, I think what we can say is that the aromatase inhibitors given at some point in time to a postmenopausal woman decreases the risk of a recurrence. The impact on survival is far, far more modest. In some of the studies, there's been absolutely no improvement in survival. In some, there's been a slight trend. In others, it's just barely reached statistical significance. And with time, we may see a little more, but it's probably not going to change that much unless we come up with a way of changing our approach. Today, we heard results here in San Antonio from the TEAM trial that compared 5 years of exemestane versus a couple of years of tamoxifen followed by exemestane. And similar to the results seen with Big 198, where the same question was addressed with letrozole, there really was no striking difference between the arms. Whether a woman received tamoxifen first followed by exemestane or exemestane for the entire 5 years didn't seem to matter. She had the same outcome when all was said and done at the end of 5 years. One of the big questions when doctors are talking to patients about adjuvant hormonal therapy in the postmenopausal setting is side effects and how to put together a regimen with the fewest side effects. And very clearly, the aromatase inhibitors and tamoxifen have different side effects. Tamoxifen has a slightly increased risk of endometrial cancer and blood clots, and is associated with vaginal problems, vaginal discharge, and sometimes some bleeding. On the other hand, the aromatase inhibitors are associated with a variety of musculoskeletal problems. There's the increased risk of osteoporosis and fracture, some of which, perhaps most of which, can be ameliorated with bisphosphonates. And then there's this syndrome of arthralgias and tenosynovitis that can be very troubling to people and keeps about probably 5 to 10% of patients from taking the aromatase inhibitors after they've started it. They actually come off therapy. I think given the data, what my feeling is that we should be picking the adjuvant hormonal therapy that a patient is most likely to take. And if she doesn't take therapy, she can't be helped by it. And if she has a lot of side effects with therapy, she's unlikely to take it. So we really have to work towards tolerability, and that's going to vary from patient to patient.